really pleased also to invite the next speaker, Professor Chris Verslype from Catholic Universiteit Leuven from Belgium.
Thank you very much, Mr. Chairman. Thank you for the organizers for inviting me. In 2010, a politician in the UK, his name is Nigel, he said that Belgium was an artificial country. It would very soon split up. He also had a dream, this Nigel, about Brexit, so he realized his dream. But I can still assure you that Belgium is still existing. And so therefore, I can give you this update. So it may be in the elections that we have in a few days, in June, it may be that we will split, but it will be really a detriment and not a good thing for our system on cancer and for our patients in Belgium. So first of all, we lack a patient association in Belgium devoted to, I'm a bit jealous for the Italian anyway, but especially also for what you have established, Helen, here in this fantastic foundation. It's for me the first time that I attend this meeting. I'm still convinced that bringing researchers, clinicians and patients together at a conference is very motivating. So it keeps me thinking. So it's just cholangiocarcinoma in Belgium. I don't speak for Belgium, of course. I'm not an MP. Even it's very political. We have the north, the south. We have Brussels. We speak 3 languages. English is not an official language, so it's Dutch, French, and German. And this is the patient that I will take also back at the end of my talk, just to illustrate what's possible in our country. Yeah? So a patient with a centrally located perihilar cholangio. So some recent data, the importance of international collaboration for Belgium, this is of course crucial. And we have about 500 cases of cholangiocarcinoma a year in Belgium. So these are the figures, and we see also and you see also that approximately 20% will be diagnosed prior to 65 years. So we also have, it's taking off, of course, from 55, but we also have young patients, and these are the most clearly incidence rates that are very age-specific. So we see a rise over many years. You see some drops now recently, but we have been facing issues with COVID, that there was a late diagnosis in some tumors with delays and so on. So registration, I can reassure you that in Belgium registration is perhaps also not very perfect, but still we see over this time period a clear rise in this for age standardized incidence. So this is important that there is an increase. The survival remains poor. It's by age group that you see that it is that is really bad, I have to say. So it's a killer. And also in females, that we clearly see that there is an issue that we cannot cure the majority of these patients. More importantly, we have the stage, 35% has metastatic disease, of course, a bit more also locally advanced disease, and this is of course a big issue, how to pick up these patients earlier on. I started my career as a hepatologist. I'm always convinced that some slight disturbance in liver test should aim for a good ultrasound of the liver. And if you always think that your disturbed liver tests are coming from metabolic liver disease, you will miss potentially in an individual patient a mass in the liver. So this is for teaching, especially our medical students, but also our GPs and so on. So we have a teaching, especially we don't have luckily this opistocortis in Belgium. I hope we don't have it. I'm getting afraid with seeing when I'm eating sushi now, but anyway. So so the epidemiology is quite different, but still we are faced with a diagnosis that's made at a late stage. So I'm very proud of this collaborated effort. It was started by the Dutch, and there were 3 countries that had to validate their findings. It's a nomogram that has been developed and I remember one of the patients this morning His 10th question was, what is the prediction of recurrence with my distal cholangiocarcinoma? So he should now go to this paper. You go to the Dutch Pancreatic Club and you find a lot of many scores. You click on it, you enter your data, and you can know what is the projected 3-year survival. So this has been made up just by very good registries, data, a lot of work from the group. And Hans-Josef is here, so it was one of his fellows, PhD students, who put this together. And so this is an example of an international collaboration for a small country that we can also help in validating. And we are open in Belgium to validate also your, if you need us for something, we can help to validate your score. If it is not validated by us, you can skip the data. What is available for our patients concerning diagnostic tools? First of all, 10 million inhabitants, 11% of our gross domestic product is going to healthcare. So this is, we are in the middle of spending money for healthcare. It's universal coverage, so you have to pay your insurance. It's about 55% that you're paid as a kind of obligatory insurance if you work, of course. Then there is about 25% that is covered by the government in the taxes, and up to 18% you have to pay as a Belgian out of your own pocket for healthcare costs. So this is quite considerable, and this is in fact one of the major, this is the highest, I think, for all surrounding countries, that you have to pay 18% out of your pocket. You can have a private insurance also, but this is not for all people. So there is a considerable cost. But with this system, and this is for entire country, federal, so not regional. So this is very well established, the social security, which has been, after the Second World War, I have to say, this was one of the most remarkable achievements in Belgium. And we have to keep this system, but all patients have access to all imaging tools. So CT, MRI, FDG PET. I'm not convinced that we have to do an FDG PET in all patients, and especially not, I'm not agreeing with everything that has been said today, and especially not with these guidelines. It's a good effort, but we have these tools available, and we should use them properly. So we have them, but we are still lacking good guidance in where we have to use these PETs appropriately. Anyway, having said that, there are no restrictions. So, except for the fact that our public system is not able to reimburse all the costs. And so still, we have to take into account that there is always a cost for a patient, even if we're doing a PET in all patients. So we have a considerable moral obligation, because it's taking money out of the pocket of the patient every time that we ask something. For a single test, even an AST, is for some patients an additional cost of 50 cents. So we have to be very careful about asking tests. Everything costs to the patient. The molecular testing for cholangiocarcinoma is an issue. Only FGFR2 testing is really reimbursed. This is exactly what we get as a lab in our university hospital. But if you want to do RNA sequencing, and you need to do that to pick up all the other drivers, and especially all the fusions, it costs 600 euros. I can only say for Leuven that we pay this for our patients, but that's not available in all hospitals. So don't come all to Leuven for your tests. But it's a kind of obligation that we really feel that we have to do this, but still it's not reimbursed, in fact, for our patients. That's why we don't do it always at diagnosis. So we wait a little bit because of the additional costs, and the turnaround time is rather quick. That's fine. So considering therapy, we have reimbursement of chemotherapy and immunotherapy, Durva, and even Pembro now in first line. So that's covered. And for target agents, it's quite comparable with Italy. So pemigatinib is approved and reimbursed. Entrectinib, so an agnostic therapy for NTRK fusions. Ivosidenib, only in the context of the clinical trial, phase 3B, so we are in the same system that patients are on a list and waiting and so on. And for BRAF and HER2, it's a big question mark, and so there we need to be a bit creative, negotiation with companies, and not a real medical need, but we have to really be good diplomats and advocates for our patients to get all the drugs. So coming back to this patient, 39 years old, and it's a long history. It started off with a clearly unresectable disease, jaundice. Then the patient went to resection, re-resection, even radiotherapy because of positive margins. She was fed up with chemotherapy. But at a certain stage, we tested for, we did a molecular analysis and we found FGFR2 fusion, and we started her on pemigatinib. So in February 2022. And she had a major response of the residual disease, and we thought it was a kind of complete response, but of course, as you know, we fear disease recurrence, resistance, and so on. And we could transplant this patient in November 2023, and we found no residual disease in the explant, and today she is free of disease and also of side effects, because pemigatinib caused serious side effects on her nails, on her hands, and so on. So what about this liver transplantation? This is an example of what is possible in our country. We have 25, we have the highest liver transplant rate per capita in Belgium, 25 donor livers per million inhabitants. I don't know the figures in the UK, but it may be half, I don't know, even better now, I don't know, I'm not aware of the recent figures. Half of our patients have marginal livers, and what we do in Leuven, we put them on a perfusion machine, these marginal livers, and we increase their quality. So we have of course a good legislation on donor liver donation and so on. So this helps us that we can make in individual cases a possibility for a transplant, but still this is not mainstream. And this entire story would not have been possible because of the first referral of a colleague who was working in a peripheral hospital, that he referred the patient to our center. And of course, the motivation of the patient herself to be referred. And therefore, I think one of the major issues is that this type of conferences are really mandatory to organize together with patients to get them motivated enough to ask questions. So I'm a fan of what you have done today, and I want to conclude. In Belgium, cholangiocarcinoma is on the rise. Only a minority of patients may be cured, that's true. Patients have access to all necessary diagnostic tools, but reimbursement for molecular tests is clearly insufficient. I hope this will change, but of course, having a nice result on a molecular test and no drug to offer can also be very frustrating. So we should really aim for testing coupled with therapeutic options. We have no restrictions on surgery except for the fact that pancreatic surgery now is limited to high-volume hospitals, and at least the distal choledocus is really controlled by a high-volume center, but what you do up to in the liver and so on, we have no control whatsoever. So this audit that I have seen today is a very nice idea to investigate. So it's one of the first things I will do on Monday next week, and approach my friend at the government to organize an audit perhaps for cholangio. Patients have access to chemotherapy and immune therapy in first line. Having said that, it may be interesting to know which patients are benefiting, and I have not shown you any slides on research that we are doing, but we are quite active in Leuven on that. But that's for a later talk, I think. And considering targeted agents, pemigatinib and entrectinib are available, but others are not available. And we depend on collaboration in clinical studies. And in Belgium, we are always willing to collaborate in clinical trials. You can always approach me or one of my colleagues. And I thank you very much for your attention.